Good afternoon to all of you.
Kisali,
I welcome all the consultants, PG trainees, and all others. Today, we need case discussion. College of Chemical Pathology of Sri Lanka is organizing these case discussion meetings as suggested by Curriculum Revision Committee of PGIN, and hope you all will participate in this academic event in future. Please send your interesting cases to college and we will organize the meetings accordingly. And we are waiting for your cases. After you will get day-to-day interesting cases. We really like to hear and see your cases. So please send those cases to us. I must thank all the trainees who sent cases to this meeting today, namely Dr. Diniti, Dr. Dinu, and Dr. Krishanti, currently working at Apeksha Hospital, Maharagama. They will discuss today cases based on plasma cell disorders. Also, I must thank Dr. Rajitha Samarasinghe, consultant pathologist of Apeksha Hospital, for her valuable contribution for this event. Hope this will be a valuable learning experience to all of you who have joined today. Over to you, Diniti, Dinu, and Krishanti.
Yeah, thank you, madam. Can you all hear us clearly?
Yes.
Okay.
Okay. Just talk and say.
Can you all hear and see the slides properly?
Yeah, slides we can see the volume. Others can you all hear?
Yes, can hear.
Yes, we can hear.
Okay, they are telling they can hear anyway. We will disturb you if we can't hear. You continue.
Okay, ma'am, thank you. Good afternoon, everyone. So our topic for today is plasma cell disorders. We are planning to take you through a case series covering multiple myeloma, smoldering multiple myeloma, non-secretory myeloma, MGUS, salted plasmacytoma, amyloidosis, and Waldenström macroglobulinemia, and Poem syndrome. So we'll first start with the case 1. This is a 63-year-old female who was under investigation for chronic back pain and easy fatigability. She was found to have high ESR of 100 and nomochromic nomocytic anemia. Further investigation revealed high serum creatinine of 150 and increased total calcium of 2.9. And her X-ray, the skeletal survey was normal and no little lesion was found. So she was proceed with this serum protein electrophoresis. Hope you appreciate the diminished albumin band here and monoclonal band in gamma region with prominent immunoparesis with paraprotein level of 73.8. This is her IFIX. Hope you can see this is positive for IgG kappa here. IgG kappa. And this is her serum-free light chain report. She had a kappa of 136 with lambda 90 with ratio kappa to lambda ratio of 7, which is abnormal. And she underwent beta-2 microglobulin, which is important for staging and prognosis, and it was within normal range. It came as 1.9. And her bone marrow biopsy was positive for plasma cell and it was 15%. So this is, in summary, this is an elderly female patient who was under investigation for chronic back pain and easy fatigability and found to have nomochromic nomocytic anemia with high ESR and with marked rouleau formation. And also she was found to have hypercalcemia and impaired renal functions with monoclonal band with IgG kappa, and bone marrow was positive for plasma cells of 15%. So diagnosis workup for this patient will be done by our madam.
So this is a plain and simple heavy chain multiple myeloma. So you see the monoclonal band, and you do the eye fix, there is IgG kappa and the light chains. You can see the deranged light chain pattern with the elevated kappa lambda ratio in this patient, and the bone marrow biopsy showed 15% plasma cells. So we International Myeloma Working Group classification, you can see now it says you have to have clonal bone marrow plasma cells more than 10% or biopsy proven bone plasmacytoma, and any one or more, make sure and, right, and any one or more of the following CRAB features or myeloma defining events or MDE. Now these patients, now you know very well the CRAB features. I'm not going to tell you one by one. And these are myeloma defining events. 60% of or greater clonal plasma cells, involved, uninvolved free light chain ratio more than 100, or MRI evidence of a focal lesion of at least 5 millimeters or more. Patients, we had a clonal bone marrow plasma cells of more than 10%, which is he had a hypercalcemia, but not to this given level. But he had enough criteria to get the diagnosis of heavy chain multiple myeloma because he was anemic, hypercalcemic, and cells more than 10%. So we go to the next case.
So this is our second case. This is 60-year-old male patient who was referred to a teaching hospital from a geriatric clinic for unintentional weight loss of 6 kilos over last 1 year duration. He was found to have elevated ESR of 88 with normal full blood count, with normal hemoglobin, and all normal creatinine, calcium, and skeletal survey as well. So he was proceed with this serum fluorescence and found a small monoclonal band in gamma region with paraprotein level of 2.5. This is his serum free light chain report. He had a kappa of 8.3 and lambda 74 with ratio of 0.11, which is normal. And hope you can appreciate he had this plasma cells of 27%. In summary, this is an elderly male patient who is under investigation for unintentional weight loss with a high ESR and Rule formation, and he had small monoclonal band in serum protein electrophoresis with 27% of plasma cells in bone marrow with no CRAB features or myeloma defining events.
So this patient was categorized as having a smoldering multiple myeloma, right? Now you saw the patient only complaint had been unintentional weight loss and no pancytopenia. Only investigational finding at this point was high ESR. So you saw a very small monoclonal band here. Deranged kappa lambda ratio, which is low, and bone marrow biopsy 27% of plasma cells. So the classification for this, the criteria for small vein multiple myeloma is there were two criteria, and where you have to meet both the criteria. One is serum monoclonal protein more than 30 grams per liter, or urinary monoclonal protein more than 500 milligrams per day, or clonal bone marrow plasma cells of 10 to 60%. So here this patient has 27% plasma cells. So he met this criteria, and absence of myeloma defining events of amyloidosis. You can remember the myeloma defining events that we have mentioned earlier. So he didn't have any of those things. So this was categorized as smoldering multiple myeloma. So in these patients, you have to follow the patient up carefully, because at any point that this patient can go into overt multiple myeloma. So you have to do the routine follow-up by doing electrolysis and serum free light chain assays in these patients.
So in our next case, we have a 52-year-old female who presented with altered bowel habits for 3 months, which was mainly diarrhea, PR bleeding, exertional dyspnea, bilateral lower limb swelling, proteinuria, and bilateral upper limb paresthesia. Basic investigations revealed a hemoglobin level of 9.1 gram per deciliter. And other than that, the basic investigations were normal. But a 2D echo revealed features suggestive of congestive heart failure with preserved ejection fraction, which was supported by elevated BNP level of 144.4. And also, the urine protein creatinine ratio was elevated 76.6 milligrams per millimole. This is a serum protein electrophoresis report, which is normal except for immunoparesis. And this is the serum immunofixation report, which is also normal. And her urine protein immunofixation report revealed monoclonal excretion of kappa chain fragments. This is her serum free light chain assay, which revealed elevated kappa of 168, lambda of 22.97, and an abnormal ratio of 7.3. She underwent further investigations. Her lower GI endoscopy revealed diffuse yellow deposits in the mucosa in rectum and descending colon, and there was a polyp in the descending colon, which was excised and sent for histology. The histology report of this polyp was compatible with amyloidosis, and it was confirmed by congruent staining. The bone marrow biopsy, her bone marrow biopsy, there was no lymphocytic infiltration or feature suggestive of multiple myeloma. So in summary, this is a 52-year-old patient, female patient with multiple complaints with normocytic normochromic anemia, elevated urine protein creatinine ratio, and features suggestive of congenital heart failure with elevated BNP and suggestive 2D echo, and elevated kappa light chains, and histologically confirmed amyloidosis with normal bone marrow.
So this patient, now how do we suspect that this patient is having systemic amyloidosis? So one thing is to start with here. Now he had a congestive cardiac failure and protein excretion, urinary protein excretion. And on investigation, it's actually basically this is a multi-system, right? Low HB and cardiac. And I think here diarrhea also. So diarrhea, cardiac congestive cardiac failure, and low hemoglobin. So when a patient presents to you with any of these multi-system complaints and investigative findings, you have to think of amyloidosis. So here, no band but hypogammaglobulinemia, normal, and but serum free light chains, you can see the deranged kappa lambda ratio where kappa levels are quite high. At this point, you can basically start investigations investigating towards amyloidosis, systemic amyloidosis. Now, we have done this, and criteria necessary for diagnose systemic amyloidosis. Now here, the presence of an amyloid-related systemic syndrome in which this patient presented with. He had renal issues, cardiac, GIT, and positive amyloid staining of congruent found in any tissue. Now he had a bowel polyp with congruent positive. And other features are either evidence that amyloid is light chain related system by examination of the amyloid using mass spectrometry, or evidence of a monoclonal plasma cell proliferation disorder. Now this person has an abnormal free light chain ratio, right? But his bone marrow was normal, but because he had all these positive features, systemic amyloidosis, diagnosis of systemic amyloidosis was made.
In our next case, there is a 42-year-old male who was investigated for persistent right shoulder with restricted movements for 3 months. So all his basic investigations were normal. So he underwent a cervical MRI, which revealed the expansile mass involving the right scapular body, bony labrum, and the coracoid process. So the true cut biopsy of the right scapular mass was suggestive of plasmacytoma. He also underwent bone marrow biopsy, which was normal with 1% of plasma cells. In the skeletal survey also, there was no other lesions. Urine Bence-Jones was negative, and the serum free light chain assay revealed the elevated kappa of 24.2, lambda 41.3, but with a normal ratio of 0.59. So this is his serum protein electrophoresis report. There is a small monoclonal band with a paraprotein level of 8.4 grams per liter. And in summary, this patient has positive features in the MRI and the histologically proven plasmacytoma with normal bone marrow and a small monoclonal band. So the diagnosis of plasmacytoma was made, and the diagnosis workup will be discussed by our manager.
So this patient again came with a shoulder pain with restricted movements, right? And basically his basic investigations were unremarkable, but cervical MRI, there has been an expansile mass. Now usually these plasmacytomas, they are solitary lesions, solitary body lesions, which are localized but very, very destructive, right? They can destruct surrounding bone tissues and other tissues. And if this happens, I once saw a patient with a solitary plasmacytoma in the hip joint, and where he couldn't walk till the chemotherapy and therapy was completed, because that lesion is very, very destructive. So here there is a expansile mass in the right scapular body. So at this point, these are the differential diagnosis made, and then they went into, once you do the biopsy, we can say it is a solitary plasmacytomas, but you will not see any significant things in the bone marrow. Only in the electrophoresis you will see a small band. Sometimes you will see larger bands. Here in this patient, there's a small band. And this is the diagnostic criteria or the things that we have to confirm the diagnosis of a solitary plasmacytoma. So it should be a biopsy proven solitary lesion in the bone or soft tissue. But the bone marrow has to be normal. There should not be any evidence of clonal plasma cell proliferations, and the skeletal survey should be normal. That means it has to be a single solitary lesion, and there should not be any crab lesions or myeloma defining events in those patients. So plasmacytomas are solitary plasma cell proliferating lesions which are locally destructive chemotherapy.
Next two cases are same diagnosis with the two different electrophoresis finding. In which case one is a 60-year-old patient, previously healthy male, presented with a history of back pain, loss of weight, loss of appetite, and generalized weakness for 1 month duration. On investigation, having anemia of 8.9 gram per deciliter of hemoglobin and ESR 100 millimeter per first hour, and serum creatinine is significantly elevated with 1236 micromole per liter, and both total calcium and ionized calcium are elevated. Total calcium is 3.1 millimole per liter, and the ionized calcium is 1.87 millimole per liter. And on blood picture, patient is having normocytic normochromic anemia with Brule formation. And skeletal survey reveal lytic lesion in the skull and femoral head with L1 vertebral fracture. This is the patient's serum electrophoresis report, which reveal mild hypoalbuminemia with hypogammaglobulinemia. Then we proceed with serum immunofixation, which was monoclonal excretion of lambda light chain. Then we did the urine protein immunofixation, which was monoclonal excretion of free lambda light chains. And the fragment also noted. Then followed with free light chain assay. Patient is having significantly elevated lambda light chain of 30,350 lambda, and then we calculate the ratio. Ratio came more than 100. And bone marrow biopsy revealed 42% of the plasma cell. In summary, this patient was investigated for 60-year-old patient, investigated for loss of weight, loss of appetite, and back pain, found to have normocytic normochremic anemia with high ESR with marked ruler formation, and hypercalcemia with impaired renal function, and investigation found to have hypogammaglobulinemia with light chain, lambda light chain in immunofixation, and increased light chain in the free light chain assay with 42% of plasma cell in bone marrow.
So this is a patient with light chain myeloma. Now you all know in light chain myeloma, the light molecular weight of the light chains, you won't see a monoclonal band in the. This is one presentation, right? The next case will be the other presentation of a patient with light chain myeloma. Here now we didn't see a monoclonal band in the electrophoresis. Instead of that, we saw low albumin and hypogammaglobulinemia. So when you come across the patient with typical complaints of multiple myeloma with hypogammaglobulinemia, now usually patients with light chain myeloma, their presentation is more severe, right? There will be multiple lymphatic lesion, the ESR will be very, very high, and as I told you earlier, the patient can present with acute renal failure because they are more prone to cast nephropathy due to high concentrations of light chain presented to renal tubules, right? So the presentation is quite severe in light chain myelomas. So here there was hypogammaglobulinemia. Because of that, we did urine we did a immune fixation to find out. Now here you can see the lambda light chain, and it is correlating with the beta band, right? So it is superimposing with the beta band, and the intensity is much higher than the beta band itself. So I thought of not doing E and D because of this. If the intensity of this band is somewhat close to this one, I would have done E and D, but here I didn't do E and D because of the intensity of band. The lambda band was much higher here. So I thought this is a hypogammaglobulinemia. I thought this is a light chain myeloma. One thing is the patient having hypogammaglobulinemia, and the other thing is the intensity of the lambda light chain. And then we proceeded to the urine electrophoresis and the IFIX. Here, this is not a biclonal, right? Please don't think this is a biclonal because of the concentration of this light chain is quite high, and this is a sort of a small technical error that can occur when during the antigen antibody binding, this is a small technical error which occurs when the light chain concentrations are very, very high. So this is a lambda pre-lambda light chain excision together with lambda fractions. So when we do the pre-light chain assay, this is what we found. Now you can see the myeloma defining one criteria of myeloma defining event is here. Affected, unaffected ratio was more than 100, and this value you got from dilution, right? This value we got from dilution. Sometimes when this is very, very high, even your analyzer will not ask for a dilution also. So you will do the dilution depending on the appearance of the urine protein electrophoresis. So this, you know, the positive finding, the marrow cells was more than 10%, and he had hyperglycemia, there was renal insufficiency, anemia, and this also was involved uninvolved ratio was more than 100. So this was a plain and simple light chain multiple, lambda light chain multiple myeloma. Next, the other presentation is this.
Says 60-year-old previously healthy male presented with cardiac arrest. And Investigation, hemoglobin revealed 7.6 gram per deciliter anemia with serum creatinine of 860 micromole per liter, and ionized calcium was elevated, which is 1.5 millimole per liter. And patient developed cardiac arrest due to this hypercalcemia. And then we did the serum protein electrophoresis for this patient, which was hypoalbuminemia with monoclonal band in alpha 2 region with paraprotein level of 9.1 gram per liter. And then we did that serum protein electrophoresis, which shows monoclonal excretion of lambda light chain. And then we proceed with, we want to exclude END for this patient, which was excluded. And serum free light chain shows lambda light chain of 11,630 milligram per liter, and the ratio was more than 100 in this case. And bone marrow biopsy revealed 35% of the plasma cell. And in summary, this patient came with cardiac arrest and found to have normocytic normochronic anemia with hypercalcemia and impaired renal function, and monoclonal band with lambda light chain in IFIX, and increased lambda light chain in the serum free light chain assay, and positive plasma cell in bone marrow. And
So this is the presentation of a light chain myeloma. Here, sometimes some patients can present with the monoclonal band. Now here you see the monoclonal band in the alpha 2 region where a monoclonal band is not usually found, right? So depending on the patient's history, now this patient has hypercalcemia, he was in a cardiac arrest and he was in the ICU by the time we received the samples. So because the intensity of this alpha 2 band, we started to do a immune fixation where we saw this lonely lambda band, right? So in order to confirm it, we did the END also in this patient, right? We did the END of this patient, and here you see only nothing is here, so it is just the lambda light chain multiple myeloma, and his serum free light chain assay was 11,630. Here we couldn't do the urine protein electrophoresis because we should have done it. It is of investigation that should be in this patient, but this patient was treated in the ICU by the time we received the sample. This is a patient from Kandy. So we couldn't get the urine sample, and ideally in both these patients, they should have done a beta 2 microglobulin also. This is the prognostic marker, and usually these patients come with renal failure. So now the upper range of beta 2 microglobulin is 2, but some of these patients, the beta 2 microglobulins come in the range around 11 or 15 also at the time of the presentation, right? So in this patient also, and in the previous patient, we should have done the beta 2 microglobulin level also at the time of the diagnosis. So this is another presentation in light chain myeloma where a patient presented with a band, with a monoclonal band.
this is our final case. 51-year-old previously healthy male presented with history of back pain. And investigation, hemoglobin was 8.8 gram per deciliter and ESR of 54 with normal serum creatinine and total calcium, and blood picture shows leukoerythroplastic picture. And serum protein electrophoresis found only the mild hypogammaglobulinemia. And then we did the serum immunofixation, which was normal, and urine immunofixation also normal. Then we did a serum light chain assay, which also revealed normal findings. Then we followed with bone marrow biopsy, which revealed 30% of the plasma cell. So in summary, this is a patient was investigated for back pain, found to have normocytic normochronic anemia, high ESR with positive plasma cell finding with normal serum protein electrophoresis IFIX and light chain. And this case will be discussed by our madam.
So this is the in diagnosis as well as from the patient side. Most unfortunate type of multiple myeloma, right? We call it non-secretory multiple myeloma. And here you have the clinical features, and then you do the protein, serum protein electrophoresis. So in IFIX, you don't see a band, right? If you see a band, you call it secretory multiple myeloma and start investigating accordingly. If you don't band in either of these, you do the serum free light chain, and again, if you see a band, you call it oligosecretory. That is no M-band, but light chain ratio is abnormal. You call it oligosecretory, and no M-band in IFIX or SPE, light chains are normal. Then you call it non-secretory multiple myeloma, right? There's one other step we can do, but not in our country. You can look for immunoglobulins in the cytoplasm. And if there are immunoglobulins, you call it true non-secretory multiple myeloma, and it's still no non-producing multiple myeloma. So in this non-secretory multiple myeloma, there's nothing much the chemical pathology department can do, right? So you have to treat the patient, right? You have to treat the patient, and you have to follow up using either bone marrow biopsy, patient's clinical features, and in MRI or CT scanning. There's no you cannot do any chemical pathology testing because the patient is not secreting anything.
Then for the completion of our heading, the plasma cell disorder, we want to touch other three headings such as MGUS and Waldenstrom macroglobulinemia and POEMS. For the diagnosis of MGUS, patient should have these three features: the serum protein, monoclonal protein of less than 30 gram per liter, first one. Second one is the clonal bone marrow plasma cell percentage is less than 10%, and the absence of end organ damage such as hypercalcemia, renal insufficiency, anemia, and bone lesion. These all three, patient should have all three features to diagnose MGUS. And for the MGUS patient also, we have to monitor, and they can go to the smoldering or the heavy chain multiple myeloma or light chain depending on the pattern. So we have to monitor this patient also. The second one is the Waldenstrom macroglobulinemia. For the diagnosis, the serum IgM monoclonal protein level is more than 3 gram per deciliter, or bone marrow lymphoplasmacytic infiltration of more than 10%, and no evidence of any organ damage. For the diagnosis, these are the criteria. Then the third one, syndrome. For the diagnosis of POEMS syndrome, there are mandatory criteria and other additional criteria. Mandatory criteria are polyneuropathy, monoclonal plasma cell proliferation, and other minor criteria, 3 minor criteria and the 6 minor criteria. 1 out of 3 and the 1 out of 6, we can diagnose the POEMS syndrome. Here we mentioned all minor criteria. Thank you, madam.
Now we have discussed about the full range of plasma cell disorders, heavy chain diseases, 2 cases of light chain myelomas, smoldering, non-secretory, and some points about Waldenstrom and POEMS. Now, do you have any questions of these? Anybody?
Time for questions. You can ask any question. Dr. Rajitha is there. Now the team is there. You can ask clarification or anything other than even plasma cell disorders, other than these cancers even. You can ask.
Thank you, Rajitha, for very informative discussions on multiple myeloma and all the cases. Is in the light chain myeloma, the prevalence is more towards the lambda light chain or kappa light chain? Do you see the any prevalence with anything in our patients?
Actually, Dulani, I think I don't know about any prevalence of these two. But what I see is when it is lambda, the lambda levels are quite higher. I think lambda ones are a little bit prognostically bad, but I think kappa is the commoner. But I'm not very sure about that, Dulani. That I have to,
Yeah. Okay. That we also see that commonly kappa, but
commonly kappa, but when it is lambda, the lambda light chain levels are very high. So the disease wise, the lambda, if you have lambda, the prognostically, I think it's not that good. But kappa is the commoner. That is what I have seen actually.
yeah, I think better if we can do a study using the what are the information available in our patients, that we can have
Yes.
an idea. Yeah. Okay. Thank you very much.
There is a question in chat box, Rajitha, in CKD, both light chains are.
In CKD, both light chains are elevated. How the ratio is affected in C? Now, actually for CKD, now they are this myeloma working group. They are for CKD. They are working on a new range for CKD patients, right? So at the moment, we can't use the normal like the routine reference range for CKD patients. But for CKD patients, the myeloma working group is working on a constructing a new reference range for the light chain ratio in CKD patients. At the moment, we don't have.
Madam Tatsarani here. Hello.
Yeah.
Yes, Madam, these days what I am seeing here in Badula is that the follow-up patients, they are coming with very high paraprotein levels. Do you see the same picture in cancer hospital as well?
Not exactly that, Sarni, no.
So I don't know, because of these patients are like defaulted the follow-up treatment or
I don't know.
whatever.
You have to find out what are the treatment they are giving. That's another thing you have to because there are several protocols, Sarani.
All right.
No, just not one time. Like some are treated by hemato-oncology, some are treated by hematology. So
Yeah.
the protocols also differs. So that also we have to see. But here I don't see a lot of recurrences, right? Only few recurrences. Defaulted patients we get, but defaulted we can't say anything. But recurrence wise, I don't see a lot of very high paraprotein levels. No.
Madam, even in recently diagnosed patients also the reduction in paraprotein level is very, very less after first or second chemo cycle.
Not here.
I thought.
Here I have now once they start treatment, they respond quite well. Yeah.
Okay, madam.
Are resistant, but most of them respond quite well.
Okay, madam. Okay. Thank you very much, madam.
Rajitha, there is another question in chat box. In amyloidosis, is there a cutoff for
No, I can't see that. Oh, this one is here. Where is the amyloid?
In amyloidosis,
Amyloidosis, is there a cutoff for light chain ratio, madam? No.
okay. Rajitha, I think trainees may be knowing, and for urine electrophoresis, you are doing pre-concentration and doing what is
No, we don't do because this gel plate, it doesn't require the pre-concentration part, Kisali.
Okay, just early morning urine.
No, sorry.
You are just applying the early morning.
Yeah, just apply.
Okay, right. Any more?
Hello, madam. Can you hear me?
Yes, we can hear.
Shani here, madam. Just a small question. What about beta 2 microglobulin? I mean, for whom?
No, beta 2 microglobulin Kushani has to be done at the time of the diagnosis for all, right? For all, at the time of the diagnosis, beta 2 microglobulin has to be done because it's a prognostic marker. But after start treatment, you don't do beta 2 microglobulin because when you start treatment, beta 2 microglobulin transiently go up. It goes up, right? And it goes up and stabilize with the treatment. So beta 2 microglobulin has to be done before starting treatment. And it had to be done to each and every patient at the time of the diagnosis. It's a must test, like serum protein electrophoresis, but only once before treatment, right?
Yeah, yes, ma'am. Okay, thank you, madam.
Any more questions? No, I was just joking. Ask if there's anything, ask.
There's expert panel of the plasma cell disorders there. You can ask. Okay.
So this non-secretory one is the most tricky one because you don't see anything. Huh? So there are patients like that. Keep in mind, only the bone marrow findings are there. Nothing in the biochemistry.
Okay. In the absence of questions, yeah, I must thank all the trainees and Dr. Rajitha for that wonderful presentation. In the absence of further questions, I will ask Dr. Dilanti, Secretary CCPSL, to wind up the session with her closing remarks. Over to you, Dilanti.
Thank you, Dr. Kisali. I hope you all can hear me.
Yes, we can hear you, Dilanti.
Yes. First of all, let me thank Dr. Rajitha Samarasinghe, Consultant Chemical Pathologist, National Cancer Institute, Maharagama. Thank you, Madam, for organizing this event and guiding the trainees to present a very informative case discussion. Next, I would like to thank the postgraduate trainees at National Cancer Institute, Maharagama, Dr. Diniti Denipitiya, Dr. Dinudi Silva, and Dr. P. Dushyant. Finally, I would like to thank all the participants who joined us today and who made this event a success by directing questions and making the discussion very interesting. So hope to see you in another interesting case discussion like this next time. Thank you.